thanks for having me. And this is, I guess, a bit of a double act between the two of us up here. My name is Amos Folarin. I've been working in the sort of space of mobile health for the last decade. I guess I traditionally come from the kind of biological sciences, so my kind of journey is sort of a little bit more from sort of the biological sciences into sort of informatics, data science, software development domain. So I'm going to talk a little bit about the work we've been doing in this space, principally around the platform we've been working on diligently for the last 7 or 8 years. Okay. So for the talk, I'll go over Radarbase. So this is our platform for collecting data from wearable devices, phones, and mobile phone apps. I'll talk a little bit about the types of data that we're collecting with the platform, and then I'll also talk very briefly on some of the different kinds of studies we're running. So I'll leave a little bit of the actual specifics of the studies that we've been using Radarbase for, because there's another talk later on from Richard Dobson, who will have a little bit more detail on this. Alice will give you an example of the work we've been using Radarbase for in ART-CARMA, so more relevant to the consortium here. Okay. So where did this all sort of start? Well, back in sort of 2012, we were, I still had my bioinformatics cap on, and I was looking at different ways in which we could bring new types of data into the GWAS studies we were running. One of those was to basically look at data we were pulling in from the clinical records. And another opportunity that was starting to kind of, develop a little bit of legs was trying to collect data from mobile phones. So the sensors on phones, the mobile phone apps, and wearable devices. So the space then was quite simple. Fitbit was just a Fitbit Flex device, and it was essentially just an accelerometer that you wore on your wrist, and would kind of give you some indications of sleep, activity, and that was pretty much it. Mobile phones, again, back then, sort of smartphone penetration in the market was about just a little bit over 30%, compared to sort of 91 today. But we could also, see this sort of trajectory rising, and we were quite excited about the possibility of kind of like decentralizing data collection. So, wearable devices now, we're seeing sort of from this paper here in the US at least, we're talking about sort of 44% ownership in the population now. This really is kind of giving us the possibility to start doing kind of citizen science type approaches to this data collection. I'll touch a little bit on that later on the slide. And what are the kinds of things that really change with mobile health? Well, we can really do enormous scale data collection, getting really, really fine-grained pictures of people's behavior in their daily lives, getting kind of objective data, so information from sensors. So, for example, I might use a sensor to measure how well you slept or how long you slept for, rather than asking you in the morning, how well did you sleep on the questionnaire. And then we also get questionnaire data to sort of label all this sort of passive sensing data. Okay. So where are we kind of thinking potentially we could maybe make sort of some use of this, both for kind of collecting research data sets, but increasingly we're starting to think a little bit more about how this could be used as a sort of clinical tool. So whether that's taking kind of capability to sort of diagnose diseases or disorders in the general population. We're also looking at how we can use the data we're collecting in real time to trigger interventions. And then lastly, we're looking also at how we can monitor people's sort of convalescence or decline as they, how this sort of varies through the course of their disease. And I will, and for this, the types of data we're kind of collecting are typically kind of vary from quite low-level sensor information through to kind of features that maybe you're a little bit more familiar with. So for things like stress, we might collect electrodermal activity, heart rate variability, and these kinds of things, and that allows us to sort of build up a parameter, a feature of stress. So in the course of the last decade, we've seen just quite a substantial rise. In fact, this is sort of really increasing very dramatically in the last sort of few years. The types and variety of kinds of wearable devices and sensors that we're seeing enter the market, including things now like that measure sort of more metabolic, parameters like continuous glucose monitoring. Okay. Okay. So I mentioned, yes, both we're kind of in this space at the moment. For the vast majority of our interests are currently in kind of the data collection, both in real time and sort of historically of some of these data types. And I guess most of the work we're doing is in this space. But we're, as I said, increasingly kind of looking at how these could be a little bit over the horizon, how these could be used for clinical applications. I think I won't hold too long on the slide. So this is just really listing a whole load of kind of the use cases where we're interested in. So this varies from things like pharmacovigilance, so where we're kind of looking at sort of drug safety monitoring or decentralized clinical trials, all the way through to things like population health, where there's an interesting study which I'm sure Richard will touch on later, but we were collecting data from people during the COVID pandemic and looking to see whether we could use the wearable data to identify when people were infected, but also subsequently, using that to monitor people's convalescence from long COVID. And getting that kind of objective picture of long COVID was really interesting. We published a nice paper on that recently. So yes, anyway, I won't go through this, but there's lots and lots of potential use cases here for this type of information. So to actually get this information is somewhat complicated. We're talking about quite diverse sources of data, and when we first started on this road, there wasn't too much in the way of tooling available to actually help us collect this type of information. So a slightly kind of long story. We were in a position where we're thinking we could either build a specific kind of use case, or we could try and build a platform that would allow us to, essentially a box that would allow people to express their kind of research studies, their ideas. So trying to kind of build a kind of generalized solution for a platform that would allow us to collect this type of data. So on one side, we have the data producers, and then on the other side, we have data consumers. So producers include things like the mobile phone, the actual sensors like the accelerometer or the light sensor on the phone, questionnaires, apps. We can issue digital tests through the apps. Then we have things like third-party APIs. So might include things like collecting weather information, or might include things like collecting data back from devices like Fitbit and Garmin. And again, I'll come on to sort of some of these later on. Then yes, we have kind of wearable devices where we can either collect the data directly from the wearable device, where we have some information from the vendor of that device that allows us to speak directly to this. Then on the other side, we have kind of consumers where we are. This could include putting information back to the participants, as I mentioned, sort of where we're trying to kind of either issue some kind of intervention. These could also go into sort of things like clinical applications, so maybe some kind of risk profiling dashboard. But principally, I guess most of the work we're doing, as I said, is really collecting research data sets at the moment. So we needed something to sit in the middle of that space and handle this. And the classic kind of volume, velocity, and variety of complexity kind of apply in the engineering of this. And yeah, we had to build this. So what were the kind of things we wanted to really kind of make kind of core principles here? We wanted to build an open source platform. So there wasn't anything really kind of matching Radarbase in this space in the open source arena. We'd had some kind of commercial versions of platforms, but nothing really, that would address the kind of use cases we wanted to put this to. Then the other kind of key part of this was we needed to build a platform that was scalable. That was a key kind of differentiator from anything else that was out there at the time we started. We wanted to be able to consume the data in real time and actually do things with that data as we were consuming it. Then lastly, we wanted to be able to allow people to deploy Radarbase themselves, so they can own the entire kind of chain of the infrastructure. So rather than having one big deployment of Radarbase and then allowing people to collect that, you can actually deploy Radarbase yourself and in your hospital or your institution. So that multi-tenancy is again something is quite important. And then finally, we wanted the platform to be extensible because we could see that the picture was a sort of developing one, and we didn't want to kind of commit to too much to specific kind of use cases or specific devices. So extensibility and allowing people to kind of add new devices as they kind of came into the market was a key principle for us too. So taking those into sort of mind, we started building Radar Base. So Radar, I should also mention, also started in another IMI project. So a project called Radar CNS that was looking at collecting data from people with depression, epilepsy, and multiple sclerosis. So we started this back in sort of building the actual platform early in sort of 2016. We'd been working in this sort of space a little bit before, but actually starting work on Radar Base was sort of around back in 2016. And we started the first sort of Radar CNS study, started recruiting participants about a year later on an early version of the platform. 2018, we actually gave it a name, Radar Base, and released that piece of software initially, the first version of it, as an open source project. That was then reused in a sister project, another IMI project called Radar AD, was looking at Alzheimer's patients. And then lastly, towards more kind of modern times, we're kind of seeing kind of uptake in sort of the kind of commercial space, but also a wide range of sort of research use cases. Okay, so tons of challenges. I won't sort of dwell on this, but lots of things in sort of how we go about kind of regulation, how we kind of what we can do in the way of sort of standardizing data, things like longer term challenges like integration into data into clinical records. All of these things are relatively in kind of various states of being kind of trying to be solved. Okay, so a little kind of overview of Radar and kind of the things it's sort of doing. So we have a passive app. Sorry, this is a slightly older version of the passive app in the slide. And here we can collect data over Bluetooth from devices. Then there is ability to connect REST APIs. So this is probably one of the principal sources of most of the data we collect is actually just integrating through REST APIs. So an example of that would be collecting data from Fitbit. So Fitbit doesn't allow us to directly speak to the device, but we can retrieve the data back from the vendor. And then more recently, we have a kind of initial extension to allow us to collect data from IoT sensors. So these are more sort of static sensors that we can deploy in the environment of participants. Then the other app we have in Radar is something called the Active app, and this is where people actually need to make some conscious effort when they're generating data. So the Active app is principally our kind of questionnaire app, if you like, but we also do a range of other things. And again, I'll touch upon some of those later. There's some management user interfaces. We collect data sort of both in real time, but also store that historically. We can trigger interventions based on the data coming in and being processed in real time, and we can do kind of visualization. So we have a lot of devices we've managed to kind of integrate thus far. There's still kind of a lot more on the kind of roadmap. And then lastly, a more recent sort of development now is we can issue we can create a sort of a self-enrollment portal that will allow people to remotely onboard themselves into the platform. So essentially you get a study-specific web page, and then you can do all of your kind of eligibility criteria, check, consent. Participants would create an account on Radar Base, and then they'll proceed to sort of link their devices and essentially do all of this onboarding themselves. So we kind of save a lot of costs for RAs and management of kind of onboarding of participants. So this is sort of a relatively new development. So this is a little bit newer than what we have been using recently in ART-CARMA. So I'll just touch on sort of the data we're kind of integrating in Radar. So I mentioned we have this Active app that we use to manage questionnaires. We use it to essentially deliver questionnaires to participants. It's very easy to use. So you can set this up with just some configuration files that define what the questionnaires are, what the sort of notification schedules are, and where you go, participants will receive those notifications to fill out those questionnaires, as those arise. We also have a few other things which we sort of more recently started to do also with the Active app, which is things like collecting speech samples as well as possible with Active app. And again, more recently, we've integrated health kits data collection. So now we can collect data from the Apple iPhone, but also the Apple Watch too. So because of the very specific way in which this works, you have to do this integration through a mobile app. So it's a little bit different to some of the other devices we use. But this is, again, something more recently we've been working on doing. So yeah, essentially, data sort of is synced with your iCloud with your mobile, your Apple phone, and then ARMT is able to pick that data up from the device and then send it into Radarbase. So the other app I mentioned, the Radarbase passive app. Here we use this for principally two main objectives. One of them is to collect data from the phone sensors. So we just, as that data is being generated by the phone, we collect that and send that to Radarbase. But also it is the means through which we do integrations of devices where we have a direct integration. So where we have a vendor SDK, we can basically talk to the device directly. So in this particular case, then the data doesn't go out to the vendor's servers. The data directly goes to Radarbase. That's a slight differentiator there. Often the type of data we're collecting in this particular way, where we want raw data off the devices, this is sort of common route through which we will do that. Normally, when you retrieve data from vendors' data portals, then this is some kind of process data. So you'll get steps rather than accelerometer or something like that. Okay, so yeah, we have a number of devices that we've integrated in this way. And again, quite a lot of data we get off the phone. This is not an exhaustive list, and quite a lot of kind of raw types of data we can kind of pull from these devices. And then I mentioned the possibility of using the server-to-server kind of collection of data from REST APIs. So this is an example of this using Fitbit and Garmin. So these APIs work slightly differently. In the case of Fitbit, we just have to keep asking Fitbit, have you got any more data? Have you got any more data? And then we basically pull the data when it's available. We have a kind of, there's one component called the REST source connector, which handles that. With Garmin devices, where their API is slightly different design. So when there is new data for a particular participant, it notifies Radarbase, and then Radarbase pulls the data, so it doesn't have to continuously pull it in that sense. It's a little bit more efficient in that way. Okay, so some devices that we integrate through their REST APIs, just some examples of those here. Then the very last sort of way in which we do data collection is where a device actually is a sort of dumb device. There's no kind of connectivity possibilities with it, but we have basically a file upload mechanism, so you can send files into links to your participants through a web portal. Essentially, it's a fairly simple mechanism, but just simplifies a little bit. It means everything kind of is running through the platform still, rather than having some parallel system to share those files. But essentially, there's the participant will log into to this upload connector and then just upload files directly. Maybe they require a cable to download the files from the device. And there's a range of things. They tend to be kind of much more kind of simpler devices. So there's a wearable camera we did through this mechanism, but also a few other kind of more kind of bespoke devices. We don't tend to use this a lot, but it is an option there, particularly maybe where people are exploring something new. Okay, I think the last bit I'll talk about is the different ways in which we are currently running studies. Almost the large majority at the moment of the work we do are just longitudinal cohorts. So these are typically sort of observations. So we're just collecting the data. We're not actually doing anything with this in real time. Just sort of hoover up the data, deposit it, store it, and then we're doing some analysis on that data. And we've been doing sort of studies that range in kind of follow-up time. So things like the radar depression study, we had a follow-up time of about 2 years. The depressive relapse is a relatively rare event, so we needed quite a long follow-up time for that study. But yeah, there are studies where we're monitoring people just for a few weeks or a month. As I mentioned, this is our most sort of common kind of modus operandi. And yeah, a whole bunch of studies. Again, you'll hear more about them maybe later today. Yeah, there were some distributed central clinical trials more recently. The work on atrial fibrillation in just a trial testing kind of some compounds. And then yes, participants can either be self-onboarded or they can be assisted to be onboarded. Yeah, essentially we just follow up them up through time. It's yeah, pretty straightforward. So again, more recently, we're looking at how we can use people's own devices. So rather than a lot of these studies where we've actually given devices over, like in ART-CARMA or a range of other things, we're realizing that there's this sort of, particularly after the pandemic, we realize that there's this huge opportunity where data already is existing in the kind of the ether out there. People have already been wearing these devices maybe for several years. That information is out there and available. We just have to find a way of reaching out to people and persuading them to donate that data. So we call these sort of citizen science studies. Here, we will almost always self-onboard the participants. So we will use something like the self-enrollment portal I mentioned earlier. Almost always the participants will be providing their own devices. And as I said, a huge advantage here is that you can get straight away multiple years worth of data, and it's really, really cheap, enormously kind of scalable. And yeah, we've kind of some really nice studies where we've started looking at this sort of approach. It's a very different sort of thing from the cohorts. So yeah, access to historical data. Nice example of this, I think Richard will mention later, is the COVID Collab study, where we had a partnership with Fitbit, and we right away, within a few months, we were recruiting 22,000 people directly into the study. And then nicely, we were able to get multiple years worth of the kind of baseline data for these participants well before the pandemic. So we could really characterize their baselines really, really well before any of the kind of complications may be introduced by things like the non-pharmaceutical interventions that were implemented. Another study we're just about to start recruitment next month, I think it will start hopefully, is one where we're looking at data from the people who've had joint surgery. So where you've had a knee surgery, knee arthroplasty, and this information is in a large registry. So everyone who has sort of knee surgery will go into this registry in the UK. We're going to recruit people from that and get them to donate their data over the course of their kind of ideally pre-surgery, but also following the kind of convalescence. Okay, so considerations for this particular approach: its advantages, it's quick, we can get data straight away. It's cheap, we can have huge data sets. Disadvantages: device heterogeneity. We obviously can't get context for the historical data. We can't retrospectively issue them questionnaires and things like that. So, but usually what we're doing here is where we have some parallel means of getting some context, whether that's from a registry or electronic health records or something like this. This is a potentially nice approach. Okay, and then yes, sort of just a quick chat on kind of real-time the real-time data processing we do. So this is a little bit of a slide I just pulled up, but a sort of an analogy of how I kind of see this. So I'm sure people have probably pulled up Google Maps and looked at the kind of traffic information there. Well, this traffic information is generated by anonymous mobile phone location data. So if you're driving along, mobile phone in your car, and that's giving you that's being collected by Google, anonymized, and then used to determine sort of traffic density. So it's one example where that real-time information is being used from these devices. Another example is where, I guess, traffic information has been sort of, municipal sort of, public transport data is being sort of shared, and you can access that in real time, know when your kind of train is arriving versus looking at a kind of static timetable that tells you, maybe your train arrives at this time. So, I mean, our thoughts are, we should be able to sort of make interesting applications in the sort of same kind of same way with health data coming from the mobile phone devices and wearables. And yes, so we're starting to do a lot of this now. Also, but I mean, it obviously has enormous application potentially in the space of the kind of clinical applications, but we're also using this a little bit in research. So one case where we do this is we collect that data, and we do something with that in some context window. That might be just as simple as sort of saying your heart rate is above this threshold, or your oxygen saturation is above that, or below that. So often quite simple kind of ideas. We also have some quite complex ideas where we've been sort of looking at how we can use this with machine learning applications. So we might have one example I'll come on to in a second, but in ART Transition, which is a follow-up study from ART-CARMA. This is again a study that is just about to start recruiting. Here we just in real time process the information coming from the questionnaires that ask a daily medication questionnaire. So of that population, people might not receive, they might not be taking medications, in which case giving them a daily questionnaire for medications is really onerous and just bothersome. So what we do is, if they've responded to say they're not taking medication, we won't issue that questionnaire basically for another month. We'll hold off issuing this daily questionnaire. But essentially, that's just a very, very simple example of using the data coming through the platform in a sort of intelligent way. And then a study I was sort of, myself and one of my PhD students were working on was looking at people with COPD and inflammatory lung disease. Here we have quite a complicated machine learning anomaly detection model that tries to establish when people are experiencing an exacerbation. So this is like a worsening of their lung disease condition. When we think we've detected one, we send them a notification with a questionnaire to sort of rate that and essentially trying to establish whether we're doing a good job of predicting when their exacerbations are. So, very, very simple use case. Not really an intervention. We don't sort of. I think once you cross over into actually doing something that is, is a clinically relevant sort of, change of their normal kind of experience, then we are treading into the kind of clinical application domain. So we have to tread a little bit carefully here where we do this kind of thing. So this second to last slide. There are a couple of ways in which you can kind of use Radarbase today. You can take the open source project, run that yourself, and it's entirely yours to manage. So we have people doing this. They deploy it themselves either on public cloud or in their institutional infrastructure. The other way is through there are a couple of companies now. One we also run called Onsentia that essentially will do that for you. So if you don't want or don't have the kind of technical means to run sort of a complicated piece of software like Radarbase, you can basically use that now as a managed service. So you can access that without, you just get a project and, we'll help you sort of set up and collect that data. So I think I'm just a little bit on time. This is just a shot of my team. Really, none of this is possible without all the kind of their efforts. And Alice, I think I'll hand over to you.
Thank you. So I'm basically just going to sort of contextualize what Amos just went through in terms of studies with individuals with ADHD, so more specifically adults with ADHD. So this is kind of just initial learnings from the ART-CARMA study. So this is learnings from the research team, but also feedback from participants as we've gone through their study period. And then also feedback from the qualitative studies, which Haley Denyer conducted at the end of the ART pilot study. So that was similar to ART-CARMA, but was a 10-week remote measurement technology study. So for a bit of context, I'm sure many of you will be aware about ART-CARMA, and you'll hear a bit more about it this week. But essentially, we enrolled 300 participants into the ART-CARMA study. Roughly half of those were in Spain, and then the other half were in at KCL in the UK. The protocols differed slightly between the two sites. In the UK, largely we completed baseline assessments with participants online over Microsoft Teams. In Spain, it was largely in person. But broadly, the protocol was that we would have 2 sessions with participants. The first one would just be assessing eligibility. And then once eligibility had sort of been established, we would then set up and send devices to our participants. So you can see the devices here, basically just a box with some weighing scales, a blood pressure monitor, a phone, and then also an Embrace Plus. So many people did have their own weighing scales or blood pressure monitors, but we decided that it was best that we provide our own just for consistency to ensure that everyone had consistent measurements. We also provided smartphones for participants who didn't have a smartphone or didn't have a compatible smartphone, because we had the 3 apps that Amos has already mentioned that I'll go through in a second. We needed to ensure that their phone was compatible with all 3 of the apps. So to make it more accessible, we decided to provide people with phones if they didn't have an appropriate phone. And then in the second baseline session was the setup of the apps. So we would enroll participants into the apps, and we would walk them through how to use it so that they could explore the apps with us present. So if they had any issues, any questions, if there were any technical problems, we could sort those while we were present and with them. And this is just an example of our team testing out all the devices. So I'll go through this very quickly because Amos has already sort of covered all of it. But in the ART-CARMA study, we have the 3 main data streams. So we have the active app, which is the radar questionnaire app. We have the wearable device, which is the Embrace Plus from Empatica, and then the radar passive app. So in terms of the radar active app, we essentially use this to send questionnaires to participants. So for ART-CARMA, we had questionnaires daily, weekly, and monthly. And what was useful with the radar app is that we could tailor these questionnaires to become available when we wanted them to be and for however long we wanted them to be. So for the daily medication questionnaire, for example, this was, as it sounds, daily, but we scheduled this to only be available from 5 p.m. Because we're a non-interventional study, we didn't want to remind or encourage people to take their medication. So we scheduled this for 5 p.m. so that it wouldn't act as that reminder. And we could also change, as I said, how long the questionnaires are open for. So the daily medication use questionnaire was open for several hours, but the monthly questionnaires were open for 3 days, just to make sure that if people were busy or at work or away from home or whatever, they could still have the chance to complete the questionnaires when they got back. And as it says, this just allowed for the sort of ease and frequency of questionnaires so that we didn't essentially have to send people frequent emails or frequent text messages, which might be harder to complete or remember to complete. So in terms of feedback from participants, luckily people generally found it quite easy to take part in the study and complete the questionnaires. However, a year is a long time. And many people reported that it did become particularly burdensome or boring, essentially. Towards the end of the year, you're asking people to complete the same questionnaire every single day for a year. Not the most exciting questionnaire, it's very short. But I'm seeing the ART-CARMA team look at each other and it became incredibly boring for participants. So the main thing with the active app, especially when you're asking participants to answer questions every day, is to maintain engagement. Reminder notifications were sent to participants. I believe there were 2 sent each day just to remind participants to complete the questionnaires when they forgot. Um, explanations of measures, thorough explanations of measures was really important in the baseline assessment. We had many people report that potentially not understanding why certain questions were asked or certain questionnaires were included, decreased motivation to then complete those questionnaires. So that is super important in the baseline assessment, but also to have frequent communication with participants. So if they do start to drop off or not really see the point in why they're answering these questions, just to have open communication with them. And then streaks and badges, I won't go into too much, but this is essentially one of the PhD students, the name is his team, Pauline, who was here last night, is looking at whether streaks and badges, so think sort of Duolingo streaks of you've answered questions for this many days, and various other components that will hopefully increase compliance and just sort of that additional motivation to continue in the study once the initial motivation is worn off. We then have the wearable device, which, as I said, is the Embrace Plus from Empatica. And this, as Amos has already gone through, it doesn't rely on self-report. It's sort of an objective measure of sleep, physical activity, and so on. So one thing to note for the use of the Embrace Plus, or I think wearable devices in general, is this sort of trade-off between feedback and function. So what I mean by that is, in our study, we were an observational, non-interventional study. We didn't want to influence people's behavior at all. We just wanted to observe it as it happened. So because of that, we limited how much was fed back to the participants. So they weren't shown their physical activity or their sleep. They were shown heart rate and skin temperature. So basically things that they couldn't really control. So this made sense for our study, but obviously it was mentioned by participants that that meant that there was no real benefit to them for wearing it because they weren't seeing any of the data that we were collecting. Again, that did make sense for ART-CARMA, particularly in sort of its non-interventional design. But it is sort of a trade-off and will be individual to each study. These were some challenges that were reported by participants. So skin irritation, this was especially in sort of warmer weather, especially if people were engaging with physical activity, because part of our ART-CARMA was that we asked participants to wear the device 24 hours a day, essentially. They would need to charge it, but it was essentially when you're not charging it, can you please be wearing it? Because of that, and again, people wearing it for a year, that could cause skin irritation, especially if not cleaned properly. But yeah, asking people to also frequently clean the devices just adds sort of an extra burden to participants. Sensory issues, this was mentioned by several of our participants that it was just wearing a watch in general, especially while sleeping, was a challenge. I think this is especially the case when you're working with people with ADHD or autism, that the sensory issues of wearing a watch itself can be a challenge. So for this, there are sort of alternatives like the Oura Ring that Amos briefly mentioned. But yeah, this is just something important to keep in mind when conducting RMT studies with adults with ADHD. And then battery life here as well. There's always a trade-off with how much data you're collecting, how frequently you're collecting it, and then what the battery life is like. So this is super important to look into before conducting the RMT study. Just the more people have to charge their device, the more of a burden it is for them. And we did have some participants report that they had challenges with keeping up with charging the device, but also sort of keeping track of the charger and the equipment. It was basically just an added burden to them. And the more of a burden the study is, the less data we will get. So it's kind of, just trying to make sure that participants are happy and it's as easy and enjoyable as possible for them. And then in turn, we get the best data possible. And then the final app that I will go through is just the passive app. I won't go into too much detail about what it is because Amos has already spoken on that, but essentially collects background data. So that's background phone usage, background light, background noise. And this is largely um, uh, passive for participants. Generally, participants didn't have to do anything, which was good. It was, one less burden. However, there were times when there was maybe a system or software update that we'd have to get in touch and ask them to open and close it again or reinstall it. But generally, the idea with a passive app is that it's passive. There were, however, several participants who were understandably concerned with the data that's collected by the passive app. I think when you tell people that you're tracking their phone usage and their background noise and background light, that is understandably concerning. So in terms of how we dealt with those situations, it was essentially just being very clear in the data or in describing, the data that we collected. So in terms of relative location, for example, for ART-CARMA, that wasn't raw location, so we would never know where they were at any point. It was just relative, so if they moved 5 miles, we would know that they've moved. But again, we could never use the data to work out where they were. One that people tended to be quite concerned about was the background noise, people worrying that we were listening to their conversations, which we were not. But essentially then just explaining to people that how this is done is that the features are extracted from the audio. So whether it's volume, noise level, essentially, and that is then fed back to the study team, but the raw data or conversations never leaves the phone. That's not collected at all. We then offered people, if people were still concerned, we offered people a conversation with the tech team. So he or Amos, they know more about the specifics of how this technically works than I do. So that would put people's mind at ease. And then if people were still uncomfortable, the benefit of the passive app is that you can just turn certain permissions off if you'd like to. So if you're uncomfortable with background noise, you can just deny the permission for audio. So we did allow participants to basically decide what they were comfortable with, especially if they'd been in the study already. It's sort of better to lose some data points than whole participants. So they could, tailor it to their comfort levels, essentially. So this is more general feedback and the final thing that I'll go over. So longitudinal study, potential for burden and boredom. It's super important to keep people engaged, but in doing that, it's also important to understand that sort of several of our participants stopped providing data. We would then get back in touch with them or attempt to get back in touch with them. Several months later, they would get in touch and say that basically the study became too much, but they were too worried about telling us. They were worried about annoying us or us being angry with them. So that's something really important to keep in mind when contacting participants. And essentially, we obviously had our protocol. So our protocol was that if a participant had missing data for 3 days, we would then get in touch with them and basically see what is happening, if there are any issues that we can try and solve. But this does sort of need to be tailored within the scope of the protocol, but need to be tailored to participants. Some participants, when I would give them a call and speak with them, they were super grateful for the reminders and actually wanted them more frequently because it was just they were forgetting. Some people asked us politely, but still to back off a bit, because if you're messaging people constantly, it becomes incredibly overwhelming, and that actually made them less likely to then complete the questionnaires or wear the watch, because they felt just overwhelmed by the whole situation. So it does need to be somewhat tailored to the individual. And that's, it's sort of, taken the research team. It does take the research team quite a bit of time just to make sure that it is tailored to each individual. And if someone messages saying they're we've had people at a wedding, going on holiday, experiencing bereavements, and just making sure that we're not reminding people when it's inappropriate, but giving people the best support and motivation to take part in the study as possible. Um, yeah, I think that is everything. There's a lot of people involved in the ART-CARMA study. Hopefully, they're all mentioned here. And then a huge thank you to our clinic sites that have helped us with recruitment, and then obviously our participants have just done amazingly at providing us with all these data. And yeah, if anyone has any questions, please shout.